for doing this unbelievable work. Thank you, Mario. It's a pleasure to be with you.
Thank you very much, too kind. So this is my conflict of interest, and acknowledgement are for the items group. This acronym from intraocular emulsion silicone oil grading system. So Dr. Coco Martin, Ferrara, Pastor, Richman, myself, Spritz, and David Steele. So 61 years from the first use of silicone oil in humans, 29 years from the FDA approval, we are still using silicone oil. We still have the same compound with the related complication, and we still have inflammation or the complication related, and also silicone oil related visual loss. We recently published this review article where we found that the pathogenic mechanism of emulsification still is not clear, but we don't know really if it's only a matter of purity, biocompatibility. What we know that are mainly related to the amplification of surfactant imbalance. So as Professor Pastor was saying before, it's not just a matter of mechanical, it's a chemical stress that we are inducing with the surfactants, inducing a reduction of the interfacial tension. So, and in this balance, we can have endosurfactants that are inside the silicone oil itself, can be low molecular weights or something else, and biosurfactants that are the protein that are produced by the disease but our surgery. So, then use in reduction of surface tension, that means from 40 millimeter we're going to 20, we measure this about, and we induce inflammation that in turn further stimulate emulsification and amplify the problem. And then these emulsified silicone oil droplets are uptaken by microglia. So this is the problem, that the microglia activate the retinal neurodegenerative vascular damage in a chronic way, not in an acute way. So sometimes we can miss this point, that is chronic damage. First of all, our problem is that we need to recognize and grade the emulsion. Okay, so because there's not a grading. So that's why we were doing this protocol. But the main point for us was less than, the emulsification is the measured component is less than 2 microns, so we cannot see the emulsion. But, they correlate with larger silicone oil droplets. That is the main point. So the evaluation of a clinical detectable silicone oil droplets is a valid parameter to assess the intraocular emulsion. So we have been missing, as I was saying before, a system to evaluate and grade the emulsion first. So that's why our proposal was to protocolize a grading system to be used in daily clinical setting. Why? The aiming is to have a reliable evaluation and comparison of results of clinical studies. So we go through the 5 different steps: slit lamp, gonioscopy, fundus examination, and OCT on the macular, and scan done also on the optic disc. So this one seems to be very complicated. You will see then, it's very easy, just a score that we need to get. So we go first from silicone oil emulsified microbubbles, so less than 200 microns that we can see using 1 by 1 beam. Larger bubble, more than 200 microns, and hyperoleon, so we can measure in millimeters. This is the creaming, and our cutoff is in 1 and 3 millimeters. Why we are measuring in the anterior segment? Because there are several reports that say we have an endothelial cell density reduction from 5 to 80%. So this is a direct cytotoxicity effect on the endothelium. I mean, we are not sure because it's not well characterized, but if we are grading now, we can have more information. Then we move to the gonioscopy, and then so we are moving to the cutoff is 90 degrees of microbubbles presence or absence of large silicone oil bubbles. Why at the angle? Because emulsified silicone oil droplets induce a silicone oil-related ocular hypertension and glaucoma, and the mechanism is by triggering trabeculitis or mechanical obstruction. And then we move to the posterior segment. Our now cutoff is, for microbubbles, 125 microns. Why? Because it's corresponding to the diameter of an average large vein at the edge of the optic disc. So we are grading at posterior pole and in periphery, according to the grade in periphery that is covered by the emulsion, and presence of large silicon oil bubble and floating intravitreal silicon oil emulsified microbubbles. We are moving then to the scan and and macula, and we are looking if is present the emulsion epiretinally or intraretinally. Why? Because it's been described the emulsion in epiretinal tissue, in the retina, under the retina, and so subretinally. And we know that is associated to the macular changes in terms of cystoid macroedema and epiretinal membrane, reduction of retinal layer thickness, and microvascular changes. So mainly thinning of ganglion cell and inner plexiform layer. And on optic disc, the scan will tell us if it's present in the meniscus, so on the optic disc, or within the optic disc, because it's been also described the silicon oil-related optic neuropathy. So migration into the retrolaminar space and optic nerve. So this is, we are trying to cover all the options. So keeping in mind this important point, the imbalance between the surfactants, we are now have this classification where we can grade emulsion, and at the end we will have a score, and Maria Antonia Ferrara will tell better how to apply. We are now ready to run a validation study on this expert panel. Thank you.
Now it's my pleasure to introduce Maria Antonia Ferrara, which is going to provide some examples so you can exercise your mind just counting the number of points.
Thank you very much.